I'm DNB Medicine, consultant physician and diabetologist. Today we will discuss about the ARB usage in the COVID-19. To date, the 2019 novel coronavirus outbreak is being a major concern of scientific community to treat with potential medication. Following a rapid increase in the cases of COVID-19, different observational studies are undertaken to identify the possible risk factor for infection and related poor outcome. 17% diabetes cases were reported among 52 critically ill patients with COVID-19 and 16.2% diabetes and 23.7% hypertension cases were identified from 1,099 patients by one and all studies. Similarly, out of the 140 hospitalized patients, 12% diabetes cases and 30% hypertension cases were observed in critically ill patients with COVID-19. Hypertension was independent associated with severity of COVID-19 on admission. Hypertension is the risk factor for aggravation of the disease in the COVID-19 patient. A large percent of patients with hypertension undertaking the AC inhibitors and ARB was a remarkable characteristic among those presenting severe COVID-19 manifestations. These are classes of antihypertensive massively used as first-line therapy due to their additional kidney and cardiological protection that occur regardless of their use for blood pressure control. ACE2 is established as a functional receptor for the entry of SARS-CoV-2 S into cells. SARS-CoV-2 enters the host epithelial cells after a spike protein's receptor binding domain bind to the membrane-bound angiotensin converting enzyme 2 receptor. That is the AC2. AC2 is a type 1 integral membrane glycoprotein. The highest expression of AC2 is observed in the kidney, in endothelium, the lungs, and in the heart. The probable rationale proposed for the possible relation between the use of AC inhibitors and ARB, the progression of ARDS in COVID-19 is increased availability of AC2 attached to surface in the lung endothelium. An inherent effect of these two classes leading to enhanced coupling of SARS-CoV-2 and to the AC2 and its consequent cell entry. Receptor binding domain of SARS-CoV-2 has a strong interaction with AC2 and any increase of AC2 expression may potentially magnify the virus capacity to entry the cells. Distinctly, the ARB increased the angiotensin 2 availability since this class blocks its coupling with angiotensin 2 receptor, leading to compensatory upregulation of AC2 in the membrane. Cellular entry is followed by endocytosis and further viral replication and subsequent release. SARS-CoV-2, after entry into the cells, causes downregulation of further AC2 expression. AC2 is responsible for the conversion of angiotensin 2 to angiotensin 1 to 7 to inactive angiotensin 1 to 9. Downregulation of AC2 result in the unopposed action of angiotensin 2 through its angiotensin type 2 type 1 receptor. Angiotensin receptor blocker oppose the angiotensin 2's action by blocking its synthesis and receptor. Angiotensin receptor blocker may also cause overexpression of soluble form of AC2, which intercepts the binding of SARS-CoV-2 with membrane-bound AC2, thus inhibiting the viral entry into the host cell. The new data published in JAMA Network show that after adjusting for multiple variables, COVID-19 patients treated with AC inhibitors and ARBs had a significantly lower risk of death and severe adverse events, which include a need for intubation, mechanical ventilation, when compared with those not receiving the RAS inhibitors. Breast corona trial, which was presented at the ESC Congress, showed that hospitalized patients with COVID-19 who continued on their previously prescribed AC inhibitor and ARBs were not at an increased risk of dying or remaining in the hospital when compared to patients who stopped the medication. The replaced COVID trial, which was published, came to a similar conclusion. Abrupt discontinuation of therapy put them at risk of complication, rebound, exacerbation of disease. The patient with hypertension, discontinuation or switching of drug can lead to rebound hypertension and transient suboptimal control with the new agent, thus predisposing the patient to intermittent high BP fluctuation. which can augment the risk of developing cardiovascular events. Similarly, the heart failure patient, sudden discontinuation of AC inhibitor has been shown to result in deteriorating clinical status with possible relative increase in mortality. In post-myocardial infarction patient with LVD, RS blockage provides mortality benefit. Similarly, the use of AC inhibitor or ARB reduce the risk of diabetes complication in patients with diabetes. Until more data become available, we feel that continuation of AC inhibitor or ARB may or may not increase susceptibility to SARS-CoV-2 infection, but sudden discontinuation of AC inhibitor or ARB is more likely to result in decompensation of previously stable clinical state. Therefore, based on all these data, European Society of Cardiology and American College of Cardiology does not recommend the discontinuation of AC inhibitor or ARB therapy in patients with heart failure, heart hypertension, or myocardial infarction who are also suffering from SARS-CoV-2 infection. Moreover, AC2 whose expression is enhanced with the AC inhibitor or ARB therapy has the ability to suppress the inflammation has been suggested as a potential new therapy for inflammatory lung disease, cancer, diabetes, and hypertension. Given the fact that no current evidence that proves a direct causal relationship between the use of AC inhibitor and ARB and COVID-19 infectivity or mortality, and the fact that AC inhibitor or ARB have many benefit in cardiovascular disease. Thank you. Thank you so much.